very much appreciate everyone for joining and giving us 1 hour of your valuable time on a Monday night. We have an important case here because it's a patient that we see frequently. It's a patient who has end-stage renal disease, and it's a patient who has shortness of breath. And certainly the evaluation of shortness of breath is something we do frequently in the emergency department, but without a doubt is very different based on a patient's underlying problems, as well as some of those shortness of breath and type of situations. I wanted to go ahead and just start things off here by introducing our number of panelists, and I'm really pleased with who we have here today. We have Kevin Pargeter. He is a nephrologist at Adena Regional Medical Center. Cody McCoy is one of the internal medicine residents. Brit Long is an attending emergency physician at Brooke Army Hospital, as well as Patrick Sylvester, who's at the Ohio State Wexner Medical Center in both emergency medicine and internal medicine. So I'm going to go ahead and start sharing the screen here. And then what I'd like to do is go ahead and just start off from the perspective of the patient. And what I like to do is to first share the patient's story and then to progress as we go through things into the story that we hear when we are the emergency physician in the emergency department. So I'm also just waiting for half a second. Brit Long was on just a second ago. He hopefully will soon be back. And then I'm also waiting for Kevin Pargeter. So if you guys give me about 30 seconds here, I'm going to try to see if we can get them back online here. Okay, we'll keep watching out for them when they get themselves logged back on here. Okay, so Brit will be back here with us in just a second. So I'm going to go ahead and start sharing this screen again here. So these cases, there's 30 of them, and you don't need to, of course, buy the book or anything. Everything will be explained at the course of this here conference. And Brit Long was one of the chapter authors for this case here. If you scan this QR code, you'll be able to get 1 hour of free CME. Some folks have already registered, but that goes to the EADS network, and that's also something that I think you just really need to enter your name and email address, and besides that, you will get in very easily. Here's another QR code. There are no financial disclosures to make for this presentation. So these are the participants. We've introduced folks already. I'm going to go ahead and start off by telling you the patient's story. So this is a man by the name of Alan. He's struggled for years with hypertension, unsuccessfully dealing with side effects of medications, and like many people, and understandably so, has had a little bit of problem with adherence to his medications. He eventually decided to forego therapy. However, some routine follow-up outpatient blood work revealed that his creatinine level was rising, and though he initially refused what was recommended to him for dialysis because of progressive edema, fatigue, he then eventually had to progress to dialysis. So he was diagnosed with a heart disease. He had a stent placed, and in September, in the evening, he had progressive shortness of breath, prompting his daughter to say, "Enough is enough, Dad. We're getting you to the emergency department." Despite his protests, she calls 911. The EMS arrives and finds that the patient is tachypnic and hypoxemic, but alert. En route to the ED, he becomes confused and combative, and they administer some medication to help with that and put him on a CPAP. So Cody McCoy, patient arrives in the emergency department, and why don't you just go ahead and summarize the initial ED visit, and then what we're going to do as we progress through this case, as the chapters are in the Bouncebacks book. What happens is that we see the patient, we then think about what we would do next with the expert whisperers that you have on as panelists here, and then we go through clinical questions, evidence-based. Then we see what happened to the patient, what the actual provider did, and we go through different decision points. So there's 3 total decision points and all. So Cody, if you would unmute yourself and give us a synopsis of this patient's initial presentation to the ED.
Yeah, so per our initial ED note, this patient is a 79-year-old male who was brought in via EMS for shortness of breath and was placed on CPAP by EMS en route. Patient had dialysis earlier today, but had developed shortness of breath before dialysis and continued to have shortness of breath with steady decline. Patient received midazolam by EMS to help calm the patient on CPAP. The initial vitals in the ED are noted as pulse of 71, blood pressure 102 over 70, and O2 sat 100% on CPAP. No temperatures recorded. Per physical exam, this patient is thin, frail, exhibits an altered level of consciousness, and he's on CPAP machine. He does have an unremarkable cardiovascular exam, full range of motion of the neck. Mucous membranes are very dry. Lungs are clear to auscultation bilaterally with no wheezes, rales, or bronchi noted. He does have full range of motion of the extremities, and skin is warm, dry, intact, and has a normal color.
Cody, thank you so much. Brit Long, you are the chapter author. I'm going to start off with the first question to you. A differential of a shortness of breath patient is sort of like that weak and dizzy patient that we see all the time. There are so many possibilities. Narrow down maybe in a patient with end-stage renal disease, or maybe it's even expanded. Why don't you go through, before we even start this evaluation, what are the things you're thinking about as far as the differential?
Yeah, you're absolutely right. Very wide differential, a lot of different ways of approaching this as well. I like to start thinking about the airway first. Is there some sort of obstruction? Is there an issue with the lungs? Is there an issue with the vasculature? And then also the heart. But you need to keep some other things on your differential, things like neurologic conditions, acidosis, anemia. There could be a toxin like carbon monoxide toxicity, salicylate toxicity. Our patient is a dialysis patient. He's a heart failure patient. But one of the potential pitfalls with this exact patient is not having or not keeping a broad differential. You can't just focus on pulmonary edema and fluid overload. And that's where that history and exam is going to play a huge role. What's been going on? What are the exacerbating factors? When did he last get dialysis? Are there any other systemic findings? You won't always be able to get a detailed history, especially in this type of patient. He's toxic, but you work with what you have. And one of the best ways that we can narrow our differential, at least in the ED, is to wheel in an ultrasound, just bring it to the bedside, take a quick look at the heart, take a quick look at the lungs. That's going to give you a lot of information that's going to help you narrow that differential and really help focus your treatment.
So Britt, that's fantastic. And I love the ultrasound. Of course, in a busy ED, I see that used very frequently, but sometimes I see like some of these patients, I'm like, boy, why isn't there an ultrasound in that room, right? And this is like the quintessential patient that we'd want to potentially use it for. So Cody, I'm going to come back to you just for a second here before I bring some of the other panelists in here. There was one very, very important part of this history that you said, but I just want to make sure all of our listeners are aware. This isn't just a patient who got short of breath after dialysis.
Yeah, absolutely. Onset's very important. And to add on to what Dr. Long just said, not only do we have to think about what is this patient's onset of shortness of breath today, but where is he at in his dialysis schedule? Typically it's Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, what have you for most patients, but that means there's a 2-day break at the end of it. If it's after Friday, Saturday, and Sunday, patients won't be getting dialysis. So if they're going to be experiencing symptoms of shortness of breath, things associated with ESRD, for these patients too, we have to think, is this Monday? Did they just experience, or did they just get dialysis? Have they developed this shortness of breath during or after their 2-day break in their dialysis sessions?
So Patrick, you are both internal medicine and emergency medicine, although maybe I should say emergency medicine and internal medicine. So, sorry, Cody and Kevin, for having to rearrange the order of those and levels of importance. So this patient, interestingly, on the way in, became sort of agitated, a little confused, and the patient received some midazolam. Now, of course, you could always give some sort of 0.1 milligram homeopathic dose of that, but oftentimes I see a fairly good dose given by EMS. They feel comfortable with that. So let me ask you, what is your thought on a patient with all these things going on? He has some hypotension. He is or was hypoxemic before the CPAP was placed. He is now confused. What is your thought on giving a obviously potentially sedating medicine to this patient on the way in?
Yeah, so these days I spend most of my time as in the ICU as a pulmonary critical care fellow. So I get the luxury of being a Monday morning quarterback, which is tough because our EMS crews they have a tough job. They're working with even less information than we are with equally sick patients. But given that it's Monday evening, I'm allowed to be do a little quarterbacking here, and I honestly think I don't think it's a good look. I think what we have here is really a lack of information. And in the EMS, even less so. So, we're ultimately giving a therapy to facilitate our treatment, but how do we know it's the right one? We know he's hypoxemic, we know he's tachypnic, and he's in distress, but those things they tell us about gas exchange, but they don't in the level of oxygenation, but it doesn't tell us how he's ventilating. I fear if this patient's hypercarbic from underlying lung disease, or if he's compensating for a metabolic derangement, we've now given a medicine that we know is very, very effective at decreasing respiratory drive, which is only going to hurt our case in several of the possibilities. So I think it's not a good look. I think there's better alternatives. I think there's time to re-examine if we've got the right diagnosis, if CPAP's the right therapy. If you ask me to choose real quick, what's the better pharmacological choice? I think we're all thinking the same one, and it rhymes with methamphetamine. No, it's ketamine. So, something like somewhere a little less than the procedural sedation dose, somewhere between like 0.5 to 1 mg per kilo, I think would be a great starting point, and trying to preserve respiratory drive, but using it as a way of pre-actioning the patient with CPAP as they arrive to the hospital to maximize their chances of further resuscitation.
So I love those thoughts. And as far as not being a good look, I'm putting that back on myself because we have an actual nephrologist as part of this call, and I haven't even asked him to say anything yet. So Kevin Pargeter, can I just have you say hi here? You finally did log on.
Yes, this is Kevin. I did have a bit of
Okay.
technical difficulty.
Well, it was not your fault because I gave you like 10 different ways to try, and you tried all of them correctly. So it was definitely a computer thing, not a you thing. So I have got a couple questions for you now. You've heard obviously what we've been talking about so far. Before we go into anything, because I was going to ask you about the patient's blood pressure in just half a second, but I just want to follow up on that midazolam question. Before you actually specifically address midazolam versus ketamine or other types of sedating medicines, are there certain medicines that we routinely use in the emergency department, whether that's fentanyl or Dilaudid, ketamine, midazolam, Valium, Ativan? Are there certain medicines that we just need to be a little bit more cautious with these end-stage renal disease patients?
Well, it turns out the one that they picked is most especially worth avoiding. And so midazolam has a very prolonged half-life in patients on dialysis. And so it's just not recommended. It's easy for us to say that in hindsight, but we think about renal dosing, pharmacodynamics. We think about being a little bit more cautious when we hear the word end-stage renal disease. We need to take a second breath before we order any medications, whether it's for pain or for sedation. So definitely that's the case. You're right.
So oftentimes when I see these patients on dialysis, like if they're 180 over 100, I feel like they're hypotensive. I mean, they're like routinely hypertensive, like to beat the band. And this patient here, and I'll just sort of flash this chart again, is 102 over 70. To me, in like a 20-year-old athlete would be totally normotensive, but in a dialysis patient, to me seems super hypotensive. So we have on our problem list, obviously we have the hypoxemia, we have hypotension, we have the confusion, we have, if I hadn't said it already, the hypoxemia, I think I mentioned that. And I wanted to sort of have you sort of take a quick look again at the differential. I'm not sure if you're able to see your screen or not, but the differential that Brit came up with, which was very extensive. What are some of the things that you commonly see in these patients? Say, for example, he had gotten shorter breath at dialysis. What are some of the common reasons for that?
Yeah, so first of all, those blood pressures are far lower than we typically expect in our HD patients at their baseline. And then so that 102 systolic is much, that does represent hypotension for sure. And then to the second question about so during dialysis, so for patients who are hypotensive or shortness of breath, In his case, this was before dialysis onset versus those during dialysis.
Right.
So what I would consider is when we're removing fluid, that often will drop intradialytic hypotension. But then in terms of shortness of breath, there can be several things. Suppose they already have a pleural effusion, or in our patient population, they're a high risk for bacteremia. Maybe they're getting septic, or maybe there's a pneumonia if they've been in an ECF for a prolonged period or recent hospitalization. And so this differential just keeps going. It could also be if they've had malignancy or travel. We think about PE especially. And so, yeah, we could just keep going with this differential.
So Kevin, I have one final question for you then, if any of the panelists have a question for you, or, we can open the chat also for folks that have questions that they want to share, comments they want to share. So this is a question in a totally unscientific fashion. Of the patients that you see that get admitted to you, obviously to the hospitalist with you consulted, that did get shorter breath during dialysis, or something happened to them during dialysis, what percentage of those patients do you think end up getting admitted from the ED, and what percentage of those patients end up having something pretty serious going on with them?
Oh, it's using ballpark figures here. It's a very high percentage. These patients are at such high risk compared to the average population that it's better safe than sorry for at least to consider an observation admission. And then when we look back about the etiology, when we're following up on the floor or in the ICU even, so often we're finding numerous comorbidities, numerous secondary diagnoses. So it's pleural effusions often, it's anemia often, it's pneumonias, it's septic shock, it's bacteremia from their HD catheter, and UTIs, GI bleeds. There's just so many other issues that it's worth that they get admitted.
Well, Kevin, I don't want to monopolize you too much on this, but I do have a question on that UTI thing in a anuric patient. In just a few minutes, we'll come back to that. Anybody have any questions for Kevin or anything further to add before we take a quick vote about where we go next as far as intubation or waiting until we get back to some test results? All right, so why don't we just sort of go around the room here? And Patrick, why don't we start with you? So our patient's altered, shorter breath, and hypotensive. Is it time to intubate now? Patrick, what do you think?
No, it's not. We need to resuscitate this patient. I don't like where these hemodynamics are right now, and I'm looking at a SAT of 100% and thinking, you know what, I got a little bit of time to kind of tweak some things. I know that there's going to be some hemodynamic changes with intubation just from the medications I'm giving. He's already shown me he can tolerate positive pressure ventilation, but I want a little bit of time.
Gotcha. Britt, do you agree with Patrick?
Yeah, I'm absolutely on board with Patrick. The pulse ox is now 100%. It probably wasn't before when EMS first picked him up, and they made the complete right call starting non-invasive ventilation, whatever you reach for, CPAP, bilevel non-invasive positive pressure ventilation. So many benefits in patients with pulmonary edema. It can reduce that need for intubation. It can reduce mortality. And this is one of those situations that when you're thinking about intubating this type of patient, you kind of need to stop and kind of face palm. This is a very high risk situation for decompensation during your intubation attempt. He's relatively hypotensive. He was probably hypoxemic. He might be acidotic. Those are all those infamous hop killers from Scott Weingart. So you absolutely need to try to resuscitate this patient before intubating. Get that non-invasive ventilation going. Have a vasopressor like norepinephrine, at least in the room, if not already running.
I love all those thoughts. And the other thing is, all of us are wondering what this patient's SAT was at the house. And I know I drive people crazy with this, but it's hard to do. You're in the middle of something. You're trying to, the squad comes in. Our EMS folks, man, they drop that patient and they are gone. So I like to really get in there. You could find, not with this patient necessarily, but patients who have had overdose, patients who've had seizure type of activity. Was just some myoclonic jerking from a syncope episode for 10 seconds, or was an actual seizure with, tonic-clonic motions and incontinence, for example. And in the same way, this patient here, what was actually happening at the home? What history did they get from the patient's daughter who was with him? What was his stat at home? Does he use home oxygen? And did he have it on, or was it disconnected when that happened? So why don't we now see what the actual provider did, and we'll see what happened to this patient. Cody, why don't you go ahead and unmute, and you can tell us what happened next in this situation.
Yeah, so at this point, we're approximately 15 minutes after presentation. The patient was switched over to BiPAP, but did begin to show increased rate and work of breathing and is now unresponsive. Repeat blood pressure has worsened. It's now systolic 95, diastolic 61. The decision was made to intubate.
Okay, so what I wanted to do, Patrick, is start with you, obviously doing EM and IM and critical care also, of course. Anything that you're doing differently when you're intubating this end-stage renal disease patient, who we've all thought it'd be nice to have that patient resuscitated to a degree before the patient gets intubated. But now it's a little bit different than when I'd asked that question before, because now he's unresponsive and he is, acutely worsening, although still 100% sat, right? This clinician used etomidate and rock. Do you think that's good? Anything you would do differently?
I think I'd probably still pick those agents, to be honest. I think the weights or the dosages here seem like it just on face value. If this is a altered patient that is kind of elderly and frail, I wonder if the etomidate's a little high. I know we 0.3 mg per kilo, and 1 mg per kilo for the rock. The math's not really adding up here, so it seems a little etomidate heavy. This is one where I might, if he's already pretty obtunded, cheat a little bit lower, 15, 10, something like that. Again, might advocate for ketamine. Again, if you're on borderlines of hemodynamics, as Dr. Long mentioned, I think having norepinephrine on the pump, hooked to the patient, even started as you're doing this would be a good move.
That's a super important point. And based on some other data is that, if you are hypotensive when you're intubated, obviously increased risk. And then if you arrest when, peri-intubation arrest, mortality, at least based on one study by Hefner, upwards of 80% with that. So super, super concerning, and obviously why everyone wanted to sort of wait to intubate until we absolutely had to. Brit, shed some, throw some pearls with intubating this patient, who's not just a routine average intubation here, obviously a crashing patient.
Yeah, absolutely. And I agree with all of those points in terms of your induction doses. For the rocuronium, I'd probably reach for at least 1 mg per kg, if not more. I'm definitely going to go with rocuronium. You're just going to paralyze the patient for a longer duration with a higher dose. So that's not necessarily an issue. When it comes to the ketamine or etomidate, both of those are probably fine. But it's going to be the dose that really matters in this patient with the soft hemodynamics. So like you said, etomidate, maybe 0.1 mg per kg. For the ketamine, instead of that normal 1 to 2 mg per kilogram induction dose, I'm going to use something more on the realm of like 0.3 to 0.5 mg per kg. You can always redose that ketamine if they're not completely dissociated with that first dose. And then the other thing that you have to think about when you're asking for that induction med is make sure you have your post-sedation meds in the room and that you've ordered them with your initial induction medication.
Yeah, and I like that point as well as the point about the norep, because the last thing you want to do is have that hypotensive patient and then you're like trying to get the pharmacist to mix stuff up while everything is going on. So sort of anticipating that and making sure that that's what's happening. And this is a little bit of a branch point. And Kevin Pargeter, I'm going to bring you back in just half a sec here. There's a lot of different ways, physician, practice variation with, for example, with etomidate and rock. Like some people say, well, give the rock first because it takes a little bit longer to take effect. Then you can give the etomidate, and while that's sort of kicking in, then the rock will finally have kicked in, or the opposite. I have to say, honestly, in my experience, I find that rocuronium, even though supposedly it has a longer onset of action than succinylcholine, in my own personal experience, having used succinylcholine, honestly, exclusively, basically for the first 15 years of my practice, for the last 12 years, so 27, right? I find that rock is almost instantaneously, has almost an instantaneous onset of action. What do you guys think about that for the intubators in the group? And Cody, if you have experience with that, happy to have you join in on this also.
Dr. Weinstock, I think
I should ask specifically, Patrick. Sorry, go ahead.
it's okay. I think I share your experience as well. I don't make it a habit necessarily to give the Rocuronium before the etomidate, although I know, like on paper, that kind of makes sense. I think, especially when I have a patient that's already on an IMV of some kind. I mean, they're going to get the etomidate. They're now compliant. They're synchronous with what's happening with the machine. Maybe I have them a little bit head up as I give these meds. I give the rock. I basically am more or less. I'm not even as it sounds. Sometimes I'm not even watching the patient. I'm watching, the scalars on the non-invasive, and as soon as I see they start hitting the backup rate, I lay them flat and intubate. And I don't. In that time, I've sort of bagged them, if you will, kind of without having to switch devices.
Gotcha. Any thoughts on that, Brit, or it doesn't matter?
Yeah, I actually use the same exact strategy. Keep them on, and then once you start seeing them, come off, bring them back down, get them in the absolutely intubating position that's going to give you the highest risk of or the highest rate of success, and then bag that patient. Try and keep a little bit of PEEP within their lungs, and then once you've felt that the patient has been completely paralyzed, then go with your intubation attempt. But yeah, I try and keep them on that non-invasive ventilation as long as I can right before I start my intubation process.
Yeah, especially this guy's at 100%. So hopefully we've got a little bit of a margin to work with here. So Kevin, I got a bunch of rapid fire questions for you. So the first question is this. I'm thinking about, and this is a little bit of a branch point also, and I honestly know what I do, and I know what you do too, because we've worked together for a long time.
Mm-hmm.
But say, for example, we would want to give this patient, prior to intubation or after intubation, IV contrast to look for a pulmonary embolism for a CTA. What is your thought on that?
Yeah, so when these patients, if they're anuric with a long dialysis vintage, there's really not much risk, but it's those patients where they have the residual renal function, making still quite a bit of urine, so to speak. Those patients, we have more concern, and but then though the benefit, if there's far benefit greater than risk, I think back to that Annals of Emergency Medicine trial in 2017. Where that large cohort showed that there was not worsening AKI. And so if we could extrapolate that to this residual renal function, we don't want to worsen that further acutely. So yes, it is okay, in other words, for those people who don't make urine, but with caution for those who do make urine.
And Kevin, I have to say, I liked you before this program, but the fact that a nephrologist is quoting Annals of Emergency Medicine literature back to us is even better. I can see a big smile on everyone's faces here. Okay. All right. So this is also a little bit of a branch point. And one thing that you mentioned is patients who are septic. Certainly it could be hypotensive, patients who are dialysis patients who become septic. And there is so much with hospital, protocols and what we call sometimes the sepsis police. I say that in the kindest of all possible worlds, but they want to have these IV fluids. And of course, we know that you don't have to do something potentially harmful for patients, but where do you stand on this 30 ml per kilogram for actually, what we think would be sepsis, not necessarily even septic shock in patients who are dialysis patients?
Well, the dogma has been use less IV fluids in dialysis patients, but it seems that that's not wise, that these hypotensive, this particular patient's relatively hypotensive, we do not want to under resuscitate. I think back, which I'll share real briefly, an anecdotal story that if there is a problem later on from our treatments, well, dialysis, we can always remove that fluid later on. But in all respects, we don't want to under resuscitate. So I would push forward to provide an adequate IV fluids for these patients.
So I'm going to give you, as many people have heard me say in the past, the rubber meets the road, the fish are cut bait kind of question. we got this guy, his blood pressure systolic is 95. We've already talked about the fact that this is very hypotensive for dialysis patients. What would you give him milligrams per kilogram? Would you go with the whole 30, or would you start with 20 cc's per kilogram? What would you specifically do for this patient with his blood pressure?
Yeah, I would give the whole shebang. I would give all 30 cc's per kg. And that's because he already went to dialysis earlier today. I'm suspecting that this patient will have less, volume on board, and they're so hypotensive relatively. So I would give him that volume at this point until more data returns.
Okay, and then I'm going to ask you one other question here. Then we're going to ask Cody to tell us what the lab results came back as showing, and move to our next decision point. So you talked about the fact that Versed is one that you really don't like to use in patients who are dialysis patients. What medications do you use, and would be maybe your first or second line choices for sedation for these patients?
So with morphine, traditionally, we're worried about some toxic metabolites, and so that's not my first choice.
Okay.
And a lot of other providers are surprised when I talk about that. But for sedation, or pain, even like fentanyl, though it has a bad street rap with the lay population, but nevertheless, that is more preferable. We're treating pain. It can have some sedation with this guy who's already intubated. But then, so in terms of benzos, there are some other options too. But normally, by the time I get involved, the benzos have already been administered, and so it comes down to pain management when I'm involved. So try to avoid morphine. Fentanyl is more acceptable.
Gotcha. One other final question here. One of my favorite medicines of all time, and I'm sure everyone is thinking it's probably their favorite medicine also, is droperidol. Where does that play into patients who are end-stage renal disease patients?
So similar to propofol, if I'm thinking back, well, actually, is that what you're talking about? I didn't quite hear you.
Droperidol.
Okay.
So that was the one that we had used frequently, then it got sort of black boxed, and now we're sort of getting it back in. But maybe that's not one that you have great experience using.
It's not.
So,
It's not come up in my
yeah.
clinical practice, though I'm a younger, kind of early career doc. I've not come across that.
Okay, Patrick, do you have thoughts on that? Or Britt?
On droperidol specifically?
Yeah.
It's funny actually at our institution, droperidol's basically only can only order it from the ED. Actually, can't even get it upstairs in the ICU. So I don't have a ton of experience. Although I guess using its cousin, haloperidol, I don't see it as a great, early post intubation sedative or anxiolytic. I see that as more of like my exit strategy when I'm trying to facilitate ventilator synchrony like later in the hospital course. So I probably wouldn't.
Okay, gotcha. All right. So, Cody, why don't you go ahead and summarize the patient's lab results, which are now returning at decision point B.
Yeah, so we've got a white blood cell count of 4.4. The patient is anemic with a hemoglobin of 6.8. He is hypokalemic with a potassium of 2.4. Creatinine is 4.78. BUN 114. His troponin is mildly elevated at 0.04. He has normal liver enzymes and his albumin is low at 2.0. They had a post-intubation chest x-ray which showed cardiomegaly with mild pulmonary edema, moderate asymmetric left perihilar airspace disease, which could represent superimposed aspiration or pneumonia. And based on this, sepsis workup was initiated, cultures were ordered, antibiotics were also ordered. Patient was given 2 units of packed red blood cells and 40 milliequivalents of IV potassium.
Gotcha. All right, so let's do this here. And we have actually some more information here. We got some other test results which have now returned. Cody, if you want to summarize that also.
Sorry about that. Which one did I miss?
No, all good. I moved on to the next slide here. So chest x-ray, ECG.
Mm-hmm. Oh yeah, ECG did show a paced rhythm with a rate of 60 beats per minute, wide irregular complexes, which was similar to an old EKG.
Okay. Gotcha. And then the chest X-ray is one of the fantastic reads, either cardiomegaly, pulmonary edema, or pneumonia, or possible aspiration, right? So the radiologist is giving us a lot of room to work here. So let's start back with you. Actually, Brit, let's come back to you with this here. We've got a lot of data here, right? We've got the patient who's now intubated. We assume that we have appropriately sedated them post-intubation with whatever medications we're using. We have this sort of equivocal chest X-ray finding. We don't have an ultrasound finding, and the patient also has some anemia here. So, Britt, where are you going with this patient now? Because obviously, it'd be the best to snap your fingers. They get teleported up to the ICU, but not in most EDs. We're still caring for this patient.
Yeah, so one of the things is his altered mental status, his shortness of breath. There are many reasons why this patient could be altered, why he's short of breath. And whenever you give a medication for altered mental status, like the midazolam, you had mentioned droperidol and Haldol, you always need to ask why. Why is the patient altered? Why is he agitated? And in this type of patient, or any type of patient really, I like to break it into two different components, like something structural. Is there a mass? Is there some sort of bleed? Is there a stroke? And then metabolic, and a lot of metabolic issues, hypoxia, uremia, electrolyte issues, hypoglycemia. Hypoxia could have been a significant issue here. And when you look at structural causes for this patient's altered mental status, you do need to keep an intracranial hemorrhage high on your differential. These patients are at very high risk for bleeding because of that uremic platelet dysfunction, the anticoagulation. The risk of subdurals specifically is 10 to 20 times that of other patient populations. And you've all seen patients with subdurals. That presentation can range from either confusion to a true focal neurologic deficit. The other issue is an ischemic stroke, also high risk, and end-stage renal disease is a marker for poor prognosis. And either way, with this patient, we've got the glucose back. We've performed a neurologic exam. We definitely need a head CT. And you had mentioned about the infiltrate. This is a real tough one for this type of patient. He potentially could be fluid overloaded, but it's probably not the case. And unfortunately, X-ray is notoriously poor when it comes to pneumonia. At best, the sensitivity is 60% for pneumonia in end-stage renal disease patients. So 60%. The specificity is even worse. It's anywhere between 29 to 50%. And there's many other conditions that can look like pneumonia. It can look like an infiltrate. You need to think about aspiration, an effusion, a PE. Is there edema? Hopefully you have some history like cough, fever, some increased sputum production. Those all suggest pneumonia. In our patient, we don't have a great history. And also in older patients who are immunocompromised, they're not going to present all the time with that classic fever or the cough. They may present with shortness of breath and maybe some altered mental status. And again, I hate to harp on ultrasound, but this is another area where ultrasounds can be really helpful. The positive likelihood ratio for a diagnosis of pneumonia is around 16, very high. So, look for those air bronchograms, consolidations. If you're still not sure, chest CT is also much more reliable than X-ray. And in this case, the patient ended up receiving antibiotics. I think that was the right call. In the ED, we're playing to not lose. We're all about sensitivity, ruling out things. This patient's toxic. He's short of breath. Give the patient antibiotics. And in choosing the specific type of antibiotic, you can use a couple type of risk scores. There's the DRIP score that's available in MD Calc. If the patient has a score less than 4, you can give your standard community-acquired pneumonia coverage. That's going to be ceftriaxone and azithromycin. And those are really going to be the backbone components of your antibiotic therapy. I think your next question was about troponin. His troponin was 0.04, not too bad for some other troponins that I see in end-stage renal disease patients. We often just kind of associate that end-stage renal disease with the elevated troponin. There are a lot of different reasons why these patients can have an elevated troponin. None of them are good. Even low-level troponin elevations are associated with higher risk for cardiovascular complications and poor outcomes. You need to use that troponin as just part of your whole clinical picture with the EKG. And in this case, that EKG really didn't show any evidence of ST elevation MI or an acute coronary occlusion. I think your last question was on anemia. Many of these patients are going to be anemic.
Hey, before you do the anemia one, because I'm going to bring everyone sort of in to talk about that a little bit, but I've been trying in my brain to remember all of the important things I wanted to emphasize of the great stuff that you said. But one of the things was why it's, again, so important to meet that patient at the door, because this history is going to be so vitally important to us as far as some of the things, like the confusion that he had in the squad. I mean, I could understand that maybe the patient was a little confused at the home, but maybe he wasn't really talking because he was breathing so hard, right? And so maybe the paramedics thought that he decompensated on the way, or maybe they falsely attributed it to the Versed, when in fact, maybe the patient was confused when he was at the home because of a stroke, just for example, right? So I have a couple other things that I want to bring in here, but you mentioned that and getting a non-con brain scan, certainly we would do that. Kevin told us, and we all know this also, that it's okay to use contrast in these patients, right? So obviously if the benefit is potentially greater than the risk. You're doing a non-con brain, Brit. Do you also do CTA head and neck, looking for a large vessel occlusion?
I do, and in my system, it almost is automatic that we obtain a CTA of the head and neck, and that is automatically shot to our neurology folks, and they can actually look at everything, and we can make a joint decision together with the patient or the family. So it makes it much, much easier for us.
I'm saying, just to make sure we're all on the same page, specifically with this patient, you got the non-con brain, you're getting CTA head and neck at this point also?
I would.
I personally would also. I think that's a fantastic idea because, again, we are a little behind the eight ball because we just don't have a great history. And obviously, we're not able to get from the patient, and the paramedics have already gone, and there's no family here yet. So, unfortunately, even before the patient is intubated, the time was pretty brief before the patient got intubated. The other important point that you brought up was that troponin. And I oftentimes see people sort of poo-poo that minimally elevated troponin. Maybe I've done that myself in the past also. But in the same way that you're saying, I just really want to emphasize that even this is not an NSTEMI, it's a marker for potentially bad outcomes and morbidity or potentially mortality in these patients. So you could say, oh, it's because they're end-stage renal disease, and maybe it's a chicken or egg type of thing, but certainly it's something to be taken seriously and not just discounted.
Absolutely. Yeah. Don't discount that elevated troponin in this type of patient.
The final thing I was going to say, and you had so many points. See, I should have written it down on a piece of paper. But the undifferentiated hypotensive patient, so assuming we don't find pericarditis tamponade or PE, cell embolus, et cetera, of those patients, the number that I remember is about half of them will turn out to have their hypotension as a result of septic shock. So if you don't have another reason for it, like they're bleeding from their hand amputation or something, certainly getting this patient on antibiotics for that would be a good idea. So I know you and I have talked for a while here. We're going to bring the anemia part in just a second. Kevin, what are your thoughts on this troponin? I'm sure that you are consulted all the time, and people have asked this question a million times to you about, oh, well, the troponin is probably just elevated because it's cleared by the kidneys and is hanging around longer because of their end-stage renal disease.
Yes, and being an internal medicine subspecialty, I always think about the question of why and its associated factors. And so these patients, their most common cause of mortality really is cardiovascular. And so we cannot discount those slightly elevated troponins. There's likely going to be some element of cardiac complications, even during dialysis, years of it with the dialysis vintage patients. They're developing coronary cardiac fibrosis. So yes, we cannot discount it. We have to also prioritize, however, this patient's hypotension, making sure we're treating for sepsis. And then when things stabilize, assuming that troponin's not trending worse, then we can circle back to that later on in the course of their hospitalization.
And certainly if it's not a type 1 occlusive MI, right, it could be a type 2 MI when the patient is hypotensive and probably they do have some underlying atherosclerotic disease. So certainly would be something that we need to think about. Patrick, I've been ignoring you for a few minutes. There are 18 issues out here we're talking on. What are some that you feel most strongly about?
Well, I guess I I think when I look at these results, I'm still struggling with trying to figure out a unifying diagnosis. Like all these things could be little hits to a patient presenting dyspnea, but none of them are really the slam dunk. So I think as we've sort of talked about, the idea of, if you don't know, you know, play not to lose, I think comes back to mind. And to paraphrase you, so I think um, in this case, I'm concerned for sepsis is kind of what I walk out of, mostly because I can't come up with a really good other alternative explanation for his hypotension. The only thing that, I guess I kind of, be honest, I poo-pooed the troponin a little bit. We got an anemic gentleman, like within some degree of hypotension, some degree of shock. Like maybe it's me being beaten by my consultants through the years, but I think like I'm going to hear the words demand and ischemia ringing through my ears. That being said, no one ever died of serial examinations sending serial troponins. It should be flat if this is all demand, if you're getting better. I have a feeling this patient may end up getting a cardiogram, which may almost act as a stress echo in a way, and those wall motion abnormalities should stick out if they're truly under a coronary distribution. Those are some things I'm thinking about.
Awesome. A couple of things from the chat here as far as the lactate level was mentioned by David. And the Kevin, I'm going to have you sort of weigh in on the lactate. Any reason to think that we would use lactate levels any differently in patients with end-stage renal disease, or just the exact same numbers that we use with other patients?
I think we should go with our traditional approach. Even if they're ESRD, we won't want that to cloud our decision making. And so, if, for example, a patient is having a rising lactate and hypotension, that really should catch our attention. It shouldn't be written off, just like we were discussing. We shouldn't write off troponin.
Okay, yeah. And frankly, this patient here, right, could have had a lactate level, could have been something helpful to us. I'm thinking we're all right in that sort of standpoint of like, yeah, nothing really like this anemia, and we're going to talk about that in a second, or this potassium level, or just some of those findings on the chest x-ray. None of them really totally bring all of this together as far as this patient's clinical condition here. So why don't we, before we get some wrap-up points, and again, anyone from the chat that has any questions for any of the panelists, please put your question or your thoughts, because there's tons of expertise on this call here. Put your thoughts in the chat here, and I'll read them out to everybody. But what do you guys think? We'll go around with everybody here with renal failure patients with anemia, because 6.8 with any of the folks on this call, I would definitely be concerned about. But 7.3, 7.5, whatever, in patients with that are dialysis patients, seems like about what I normally come to. So Kevin, we'll take you last. Britt, why don't you sort of go in, because I cut you off before. You didn't think it'd be this long until you got to weigh in on the anemia part, did you?
Yeah, just keeping me waiting here.
Right, all of us, right? For your wisdom. So why don't you, and then we can go to Patrick next. If Cody has some thoughts, then we'll go to Kevin for thoughts on anemia in renal failure patients.
Yeah, it kind of seems like the unifying theme here. There's so many causes for all of these patient conditions that we're talking about, and anemia is no different in this type of patients. Most of these patients are going to have a normochromic, normocytic anemia, and that's an MCV of 80 to 100. They have decreased production of RBCs, decreased erythropoietin. There's increased RBC destruction. They can have blood loss, nutritional deficiencies. So a lot of different causes. And as that GFR worsens, that hematocrit, the hemoglobin are both going to decrease. And many of these patients, like you said, are going to stabilize around that 7 to 8 mark. And, when it comes to figuring out whether you need to transfuse the patients, obviously, if they're bleeding, there's hypotension, give them blood. If they have anemia that's symptomatic or a hemoglobin of less than 7, then I'm also going to be definitely giving them blood.
Gotcha. Patrick, what do you think? Patrick, what do you think?
Yeah, the anemia is interesting, and I think so far the history hasn't given us a good example or a good reason of why this patient is so anemic. We also don't have a baseline, so those are things I tried to tease out. But something I would point out, there's an H that's conspicuously missing from this list of lab results, and it's one that could tie to the anemia. It could be nothing, but the BUN is 114. And granted, this is a patient with end-stage renal disease, but if I'm gathering the history right, this patient just had dialysis, so presumably there was some clearance of, nitrogenous products in his blood. So why is this BUN 117 or 114? The other things that can do that are just catabolic states, sepsis, if he was on steroids. But the one I think we're all kind of now thinking about right now is he having a GI hemorrhage and ingesting all of those nitrogenous products. So a quick lavage or hook his OG to suction, see what comes out, I think would be prudent here.
Okay, so I'm going to ask you for your thoughts quick, Cody, and then Kevin. But real quick, Jennifer asked in the chat, was a focus done on the patient in the ED? And the answer is no. And then David said would want to eventually, and I think in the same way that we're all talking about here, try to figure out why the hemoglobin is low. Or Patrick, like you said, maybe we checked the previous 5 visits and the hemoglobin was exactly 6.8 on each of them, right? Cody, any thoughts on the anemia?
Yeah, once this patient's admitted and us as the internal medicine residents take him, that's the first thing I would have thought about, is that BUN significantly more elevated, proportional to that creatinine elevation. So the first thing I'm thinking, we don't know the chronicity of this specific patient, his anemia, but yeah, the first thing I'm thinking is let's consult GI. Let's see if there's a GI bleed. Let's rule out these big things. Then we can think about ordering iron panel, B12, folate, really considering those things as well.
Awesome. Kevin, you are the person to break the tie, I guess, or shed some wisdom on this. 114 after dialysis, does that seem high to you?
Very much so. There's something called the urea reduction ratio, where we should see a 70% reduction of the BUN with effective dialysis. And so the causes for that not to fall would be inadequate access. Suppose their perm cath had poor flows, or if they are in a high catabolic state. But this patient is probably having a GI bleed. And so with that new, or at least presumed, acute worsening of the hemoglobin, and then these patients, they're getting EPO routinely, they're getting IV iron routinely. Yes, they're losing a little bit of blood with each dialysis that's not quite fully returned from that extracorporeal circuit, that tubing. But still, when they're a compliant patient showing to up to all 3 treatments of they're getting enough EPO and iron, and we're aiming to keep that hemoglobin up. So there probably is an acute blood loss anemia. Anemia of end-stage renal disease, or anemia of chronic disease, as we call it, that's a diagnosis of exclusion. We need to rule out these other acute causes.
Awesome. So I'm going to just flash up here real briefly the this is the attending note, and basically when the patient got admitted, I have to say, it was a little bit unfulfilling in the sense that the patient did get transfused. They got some potassium. The blood pressure remains sort of low. They diagnosed basically the patient all the symptoms there, having respiratory distress, hypokalemia, anemia, end-stage renal disease, history of CHF, and didn't really give us a whole lot as far as the specific diagnosis with all that. And then in the hospital, they came up with a few other things here and talked about the fact that the chest x-ray showed possible pneumonia. They put the patient on some antibiotics. They maybe switched around a little bit. And hemoglobin did improve. They looked for, just like a lot of the panelists here were concerned about, any evidence of blood loss and didn't really find that. And when they rechecked the troponin level, it's also 0.04. So here's what I'm going to do. While we are going through each of us, I'm going to give us each like 60 seconds to give our closing thoughts on this case. I'm going to flash up the QR code for the CME here so people can take a look at that. And then I'll just say, eventually, after this, I'm going to have the last slide here. If folks want to sign up for our book club for next month, you can do that at bouncebacks.com. There's also links that directly I'll send out and post on Twitter and different social media for that. But for right now, here's the QR code for people to get their CME. Why don't we start, Kevin? It's been a pleasure having you here. And you have graduated from being just an IM resident to being a IM resident. So that's quite a lot you've accomplished there, right? So why don't you give me your Cody, why don't you give me your closing thoughts, and we'll sort of go, why don't we go to Patrick, next, and then we'll go to Brit, and Kevin will let you bring us home with things here. So takeaway points, practice changing points from this case, Cody.
Yeah, I think also speaking from a resident perspective, I think we have some residents listening here, some interns and some medical students. One of the things I really want to stress to our interns is when you see an ESRD patient, shortness of breath, it's very easy to think, okay, this is volume overload. Let's get nephrology on board, start dialysis, all that stuff. But don't get in tunnel vision. Really think of other differentials of shortness of breath. These are the big things we haven't ruled out. And even on top of other differentials, think of all the complications that come with ESRD, when we need to renally dose meds and all those things as well.
Patrick?
Yeah, really nice. I said, Cody. I think just like Cody said, don't have tunnel vision, but I would say the presence of ESRD is a marker of other systemic diseases that make you at risk for more things. If anything, the differential is just larger and larger as a result of that diagnosis. And other key things I heard on this was resuscitate before intubate. I heard, consider the metabolism. We've talked a lot about renal, but hepatic as well, of all the medicines we choose. And then the last one that I think point I'm going to take away, I think highlight for everyone, is the nature of emergency medicine, which is playing not to lose. I think that's a great phrase that summarizes the patient's care.
Nice. Brit Long, you are the chapter author. You've had a lot of time to think about this case, and thanks to everyone, obviously, for coming, and obviously we'll go to you, Kevin, next. But Brit, give us some takeaway points.
Yeah, they've honestly already been said. The biggest thing from this chapter, I think, is not closing that differential early and keeping it expanded, looking for all those life-threatening conditions. Ultrasound definitely can play a huge role. This patient did not receive a rush exam, but this is the perfect patient to look for that free fluid, look for tamponade, look for RV strain. What's their IVC? What does their aorta look like? All those can really help you. And then, as Patrick said, resuscitate before intubating, super, super important in this type of toxic patient.
Yeah, and to even bring that point home a little bit further, multiple people in the chat, I just see Josh, also Jennifer earlier, asked about POCUS and just how incredibly helpful that can be for so many ways. And some of the stuff that you talked about, Britt, as far as the inadequacies of the chest x-ray, right? Kevin, as a nephrologist, take home points from you.
Yes, we have to consider how end-stage patients are similar but different also from traditional patients with intact renal function. And so, for example, looking very closely at their electrolytes, looking very closely about when they last completed dialysis, also thinking about renal dosing, realizing some of the dogma of past teaching does not always apply when it comes to contrast, when it comes to other aspects of their care with volume expansion. So they're different but similar patients, but very complex. And I always like to tell people at Adena Regional, where I practice, that I'm always here to help, and any question or page is better than just going without much consideration. And so these patients, complex but very enjoyable to take care of.
Yeah, and I would just say my take-home point, really, just from hearing all the expertise on this call, is obviously avoiding that anchoring bias up front as far as just attributing everything to volume overload, especially because the patient had just completed dialysis. And then in addition to that, thinking about this hypotensive patient, because oftentimes we have a reason for it right off the bat. It's very obvious, or usually, what's going on with the patient when you walk in the room. But there are patients, legit, like this patient here, that we just don't know. And with this undifferentiated hypotension, obviously considering all these things, using ultrasound, but also really thinking about antibiotics up front for a patient who could have septic shock and making sure that lactate gets ordered. So I want to thank everyone so much. Patrick Sylvester from The Ohio State University, Brit Long from Brooke Arm Medical Center, both Kevin and Cody and myself from Adena Regional Medical Center. For folks who want to sign up for our next book club, it's the first Monday of November, November 7th. There's a 28-year-old man with a cough, and I'll just do a little foreshadowing. It is not a bacterial pneumonia. It's a patient who was admitted and then bounced back with a different diagnosis. So folks can get that. They also, the reason I'm putting this website up here is because you can see past book clubs recordings, as well as this one will be posted by probably midday tomorrow, that you'll be able to watch on the website or on YouTube. So thank you so much, everyone, for sharing your Monday night with us. I hope we were true to you, and I hope this, most importantly, will help to improve patient care. And thank you again so much to all of our panelists and time that you spent also. Thanks again, everybody. See you next month.